candidate has presented a case of asymmetric spastic paraparesis. The examination was performed in a fluent, confident and systematic way. The key areas of inspection, tone, power, reflexes, coordination and sensation were all covered. There was good assessment and analysis of gait. The candidate successfully identified the important upper motor neuron signs. There are a number of important points of technique to bear in mind in order to achieve this. When testing lower limb tone, it's important to perform a slow passive knee bend, followed by a rapid knee bend. This allows you to assess the difference in tone according to the velocity of movement. With spasticity, increased tone is velocity dependent, so the rapid movements make it more obvious. That was the case on this occasion. The candidate also did well to elicit the ankle clonus. This too requires a very rapid movement of dorsiflexion, as clonus is evidence of spasticity. Remember, rigidity is non-velocity dependent, so the speed of movement makes no difference. In this case, the knee reflexes were clearly brisk and both planters were upgoing. Remember to apply firm pressure along the lateral border of the sole and across the balls of the feet in order to check the plantar reflex. When you come across a case where the clinical signs suggest a spastic paraparesis, you'll inevitably have to generate a differential diagnosis. In terms of localization, we'd predict pathology in the spinal cord. It's important to prepare well for this sort of scenario and have a clear strategy in your mind for how you'll express your thoughts. It's very reasonable to talk in broad categories of disease. For instance, you could consider trauma, ischemia, inflammation, infection, neoplasia, as well as metabolic or nutritional disorders. As part of the questioning in this case, we talked about the investigation of MS. This is a relatively common neurological disorder and you should be familiar with it. MRI scanning is the most important investigation. It's obviously critical to scan the symptomatic part of the nervous system. However, in cases of apparently isolated transverse myelitis, which has a relatively broad differential, it can be very informative to scan the brain as well, to look for typical changes of multiple sclerosis. You should be familiar with the role of lumbar puncture in MS and the fact that the presence of oligoclonal bands can help with prognostication in a clinically isolated syndrome. In terms of treatment, you're not required to have in-depth knowledge of disease-modifying treatments. You should be aware that treatment choices in MS have moved on significantly in the last few years, and that patients will need to see a specialist to assess their options. However, you should certainly be comfortable with the use of high-dose steroids in acute relapse management. It's particularly important to be aware of the risks of high-dose steroids and how to counsel patients in that regard.